Has your patient ever asked you a nutrition question and you thought to yourself, man, I really wish I could talk to a dietitian? Or what about the random nutrition myth that your patient heard on the internet and they ask for your thoughts? Wouldn't it be nice to run those by a dietitian to get the expert's opinion? Well, my friend, today's episode is the first of a brand new series on the Exam Room Nutrition podcast called Ask the Dietitian, where I have the privilege of speaking with two guests. And rather than me doing all the questioning, I've invited a clinician in a specific field of medicine who will ask the nutrition questions they're faced with daily to a registered dietitian who is an expert in that field. It's going to be so much fun. So for our first Ask the Dietitian episode, we'll be discussing cancer nutrition. Today, you'll hear from an oncology PA who works with patients facing cancer diagnosis and treatment or who are navigating survivorship. And he'll be asking his questions to a registered dietitian who specializes in oncology nutrition. Now, we've covered a lot of ground in these interviews, so I've split them into 2 episodes. Now, stay tuned for Thursday when the second part of this interview is released. Lucky you, 2 episodes in a week. All right, let me introduce you to our guests today. Dane Thomas is a board-certified physician assistant with over 13 years of clinical experience. He graduated from Nova Southeastern University with a master's in medical science and physician assistant studies. Since graduating, he has spent most of his career educating, managing, and treating patients in oncology and hematology. He is passionate about educating clinicians and students in all aspects of medical oncology and hematology. He is a national speaker, clinical preceptor, and peer reviewer for hematology and oncology-related articles for the Journal of the American Academy of Physician Assistants. Dane is currently practicing in outpatient medical oncology and hematology in Dallas, Texas. And Julie Lanford, who you might recognize from episode 49, titled The Biggest Cancer Nutrition Myths, is a registered dietitian receiving a Bachelor's of Science in Biology from North Carolina State University and a master's degree in public health nutrition from the University of North Carolina at Chapel Hill. She has over 15 years of experience working in oncology. She also developed the website cancerdietitian.com in 2007 that translates evidence-based nutrition guidelines into consumer-friendly messages for everyday life. She hosts webinars, cooking classes, and the Cancer Dietitian podcast. Her passion is wellness for cancer prevention and survivorship, and she specializes in making healthy living fun. Isn't this going to be awesome? So friend, get comfy, and I hope you enjoy my discussion with a PA and dietitian all about cancer nutrition. Dane and Julie, thank you so much for being here. I cannot wait to get into this topic.
Thank you for having us.
Excited to be here.
This is going to be so much fun. So Dane, I'm really curious to talk to you really quickly. And we connected on LinkedIn, and I love that you reached out to me asking me about oncology nutrition. And with my connections, we were able to pull Julie on. So this is going to be a really exciting topic. But I'm just curious from PA to PA standpoint, about how many times a day do you get asked a nutrition question from your patients?
I can't think of a day that I don't get a nutrition question from any of our patients, whether they're newly diagnosed or they're currently on treatment or they're a survivor. And I get it every single day. So I'm so excited to talk to Julie about this because a lot of times we have no idea and we kind of give general information, but hopefully this will get us a better understanding and more actionable information that we can give to our patients so that they can succeed at whatever stage they're at in their journey.
Exactly. And that's the goal of my podcast. So that's why I'm so glad that you reached out, because everyone should have a registered dietitian on the team, or at least that they can refer patients to. But as you and I know, as the clinician, they're in the office asking us these questions and they're looking for that answer right then and there. And, we do want to provide helpful information. So I am so excited to get into this topic to give you these answers you're looking for. And also any other oncology clinicians who are listening, this is going to be super helpful. So Dane, I'm going to go ahead and let you take it away, and let's ask the dietitian all of your oncology nutrition questions.
Awesome. All right, Julie, you ready?
There we go.
All right. So oftentimes when patients are newly diagnosed with any type of cancer and they're about to start their treatments, whether it's chemotherapy, immunotherapy, one of the most common questions that I get is, how many calories should I be eating? What's my protein goals? How can I maintain my weight so that I can get through this treatment? So my question to you is, what is about an average caloric protein goals for these patients, and how can they maintain their weight as best as possible throughout their treatment?
So in general, and everyone's different, it really depends on what treatment the person's going to go through. Have they already lost weight sort of prior to their diagnosis, which is sometimes the thing that like brings people in to figure out what's going on. Generally, if they're just say like a typical non-stress, like not hypermetabolic kind of state, 25 to 30 calories per kilogram is what we're looking at as a general guide. If they need weight gain or like repletion, 30 to 35 calories per kilogram. If they are hypermetabolic, or if people who have the type of cancer where like it's just going to use a lot of energy, head and neck patients, some lung, or the ones that you're just are more likely to lose weight or have already, and they're going to be going through a stressful treatment, 35 would be kind of where we aim, which when you start calculating that out can be quite a lot. And that's the part that gets, I think, even harder is we can run all these calculations and tell people this is how many calories you need. But like if you're telling somebody who's not feeling well that they need to eat 2,800 calories or whatever, and then you sit down and calculate how many boost pluses that would be if they're not actually eating, we're not talking like 2 or 3 boost plus a day. It could be 5 or 6 or 7. So on the clinician side, I think having an accurate weight and then doing the calculation beforehand so that you get a sense a little bit like what we're talking about before you present it to the patient, because you're going to have to help them break it down into like, how they will realistically be able to fit that amount in. And I will add one other thing. There's a lot of discussion around if somebody has a high BMI or has an obese diagnosis, what is their calorie needs? And I will say there's not a lot of great research around that. Some people will tend to underestimate calorie needs. And I think it becomes even more up to the clinician's judgment of, we don't want people losing weight because they're not eating enough and they're not active and they're sick. If they're going to lose weight during treatment, if they're doing well, they're eating okay, and they are losing a little bit of weight and it's not affecting their treatment outcomes, okay. But if they are likely to have a lot of side effects, not get enough calories, lose muscle mass, we don't want to underestimate their needs simply because their BMI is high. So that one's a little bit harder, I think, for people to kind of figure out. So we do these calculations, but honestly, then you're just kind of like, okay, watching the weight every week, see how it's going and see what needs to be adjusted.
Before you jump into the protein, I wanted to ask a follow-up question about if we tell them you need, let's just say 3,000 calories. You mentioned Boost Plus that's out there. What are some other really quick and easy high calorie foods or ways that the PAs and the doctors can suggest to patients, even if we haven't given them a total calorie goal, but maybe of like, hey, focus on these higher calorie foods that we can keep your weight up and maintain and prevent any of this weight loss from occurring?
Yeah, so I think that's even a more realistic approach to people, is to not actually give them a goal number, but to tell them, look, you've got to eat something within an hour of waking up in the morning. You have to eat something every 2 to 3 hours, even if you don't feel hungry. This is really important. It's going to affect your outcomes. I think timing of eating regularly is important, because if you can't eat a lot at a time, it's important that you eat more frequently during the day. And then that the calorie density is as high as possible. So of course, that's going to be like as much fatty food as possible. So that means whole milk. It means the full fat versions of everything. They can add butter to like whatever they're eating. They can add peanut butter. They can add coconut oil. They can add avocado, and then they can make their own smoothies. I prefer they get their calories as much as possible from actual food, because that's going to give them fiber and lots of other helpful nutrients. But if they don't have someone who can cook for them and they don't have the energy to do it, then they can get it done with store-bought types of nutrition supplements, or a combination of mixed smoothies with store-bought nutrition supplement or with whole milk or things like that. If they're super restrictive on what they're willing to eat, I try to dig deeper into that, because that's not going to help. And usually they're restrictive because of some kind of myth, which is a whole nother topic.
No, I think that's great advice. So going along with that, what's their goals with protein? Because I got a lot of times patients focus only on protein. Oh, I need to eat protein. I need protein. But I remind them protein is one thing. Calories is really, really important too. So, okay, so we got the calories. What about protein?
We'll get back to the episode in just a minute, but I wanted to invite you to an exclusive social hour. I'm calling it the Clinician Dietitian Mixer. This will be hosted virtually, and it is by invitation only. However, if you are a registered dietitian, medical doctor, physician assistant, or nurse practitioner, you are invited. As dietitians, it is sometimes hard to find referring providers and patients to work with. And likewise, as clinicians, it's hard to find dietitians who can work with your patient. So I wanted us to join together so we can network and collaborate in a really fun, informal way. So if you are interested in joining us, this will be held virtually on Wednesday, May 29th at 7:30 p.m. Eastern Time. Registration is required to maintain the integrity of this event, but if you are interested in joining us, or if you have questions about this event, there is a link in the show notes. Please go ahead and fill out that interest form, and I can't wait to meet you. Now, if you can't make it or it's past May 29 when you're listening to this, don't worry. I will hold another social hour soon. All right, let's get back to the episode.
So protein, honestly, is actually a little bit easier when we're talking calculations. Again, this is grams of protein per kilogram. And a typical person, just general healthy, we go with 0.8 to 1. So 1 is a really easy 1 calorie per kilogram. That's the easiest if you're just trying to get a ballpark. If somebody is going to be like cachexic or have that hypermetabolic state, we might go between 1.2 and 2. 2 is typically the highest. So like 2 grams per kilogram per day is typically the highest. Generally for cancer, you could do 1 to 1.5 as a overall just general range. And so the typical American actually overeats the protein. And so they're already eating between 1 and 1.5. So for most people, they don't actually need to increase that. And I think you were right to kind of key in on calories, unless they're having food aversions or whatever. And for some reason, they're just never choosing protein. But yeah, again, it's just watching those outcomes from one week to the next and see if something needs to be tweaked. And if things aren't working for people, I have them keep a food log, or their caregiver can kind of keep a food log. Because if they keep what time they're eating, so you can start to notice if they're skipping meals, and then trying to tailor the recommendations based on what's happening rather than trying to throw all the advice at them before you actually know what's happening.
Awesome. That's great. Now, I get this question a lot. Your weight, meaning just eat as much as I can before I start my treatment. Does that help at all? Is that beneficial, or does that work against the patient? What are your thoughts about that?
That is a really interesting question, and I'm not certain that there's a lot of data on it. I would say just like, I don't know how much you could really front load, because how much time are we talking? Realistically, how much are they really going to be able to get on? But I would say, yeah, it's not a bad idea to try to make sure you get enough. I don't know about like just way overeating all the time. I'm not sure that that's really going to help a lot, but for sure, I think people being physically active and eating enough and maybe even a little bit extra before they get to the point where they're really not feeling well, at least they'll have some stores to work on. Certainly people that have 0 extra stores and then go into treatment if they have problems, that makes it difficult for their body to have something to fall back on. I do think it's hard to load in like a week's time. So I'm assuming a lot of these people don't have a lot of notice before their treatment's going to start.
Yeah, typically it's maybe 2, 3 weeks max, sometimes shorter than that. So it's not a long.
I mean, it's not a bad, I don't want people to go overboard on anything. Because I think about, well, they could do exercise and build muscle, right? Like that, they could also do that. But it seems like overdoing it would not be wise. And the same as a nutrition strategy. Yes, get enough, maybe a little extra, but don't overdo it. And again, that's not a ton of data. That's just my professional thoughts.
Julie, are there certain foods that people might consider focusing on or eating prior to treatment that might help prevent side effects or help prevent that weight loss that might be occurring? Or do you just recommend that they eat foods that they love?
For sure, eat foods that they love if it's likely that treatment's going to mess with taste buds and all those things. From a sort of mental health standpoint, people often are in a like very motivated state of I want to do whatever I can. I'm waiting for treatment to start. This thing is inside of me. It's growing. I got to do whatever I can. So if they are that type of person that's seeking control, and they're likely to go to the internet and get down a rabbit trail of alternative medicine type stuff, I for sure would focus them on, okay, here's a healthy eating plan. Like, this is what we'll recommend for you if you're doing well and as your survivorship. Like, I would tend to bring them into the survivorship eating recommendations, even at that point, even if it's like they're going to do that for a couple weeks, treatment's going to start, they're just going to eat whatever they can and then they go back to it. Because if we don't provide them with that good information, even at the beginning, and that is when they tend to be like on the internet really looking for things, they can just get way misguided and then end up kind of doing the opposite of front loading, which is not eating enough calories and being overly obsessed with food and unintentionally like using up their reserves because they've gone some really restrictive eating patterns. So I do think it's important to kind of pick up on, are they somebody who just needs to eat those comfort foods and enjoy the time that this sort of phase of, okay, you can do what you need to, and then you're going to not feel like eating? Or are they somebody who's really motivated and you got to give them the stuff they need to know so that they don't go down the wrong track? So yeah, I think kind of both of those are not too difficult to have handy without having to have too many tracks to choose from for people.
Okay, that makes a lot of sense. Now, you know, you know, you laid out a game plan about eating frequently, and you got caloric goals, protein goals, and the patient's like, "Oh yeah, I'm going to do this. I'm going to stay on top of this. I'm going to hydrate. I'm going to do all that you said." And then when treatment starts, everything goes downhill. So
Yeah.
there, lack of taste, lack of appetite. So when you have a patient that's going through that, do you have any recommendations on how to overcome the taste changes, the lack of appetite, so that they could stick with those goals that they want, that you want them to do, so that they can do the best?
Yeah, it comes down to like, which one are they dealing with? You're not able to meet your calorie needs, your weight is going down. What is it that's preventing this? Is it appetite? Is it taste changes? Is it not access to the right kinds of foods? And then just one at a time, kind of working with those. So from a taste changes standpoint, a lot of people will talk about squeezing lemon into water, not using metal silverware if they're having that metal taste in their mouth. Sometimes it's just finding things that do taste good or that taste good enough and reminding them that their nutrition plan is part of their treatment plan, and it's important that they eat even if they don't feel like it. Maximizing the calories in the foods they eat so they don't have to eat as much but still meet their calorie needs. Help them figure out if they need to just get liquid calories. Drinking things, sometimes it's just like, if you don't feel like eating, you don't want to take the energy to chew and swallow, can you just drink it through a straw? And that's just easier, like mentally, to get over that, like, oh, I have to eat something, well, I'll suck it through a straw and be done. And so really trying to key in on what you think will work and try it and check in with them and see how it's going, rather than overwhelming them with like, okay, you have this, and this. And we always would say, try the nutrition strategy first, like with the food. If that's not working, I wouldn't wait a long time until I would suggest maybe utilizing medication. So if their appetite's really awful and they're losing weight and there's nothing that's helping, then we need to get some of those appetite stimulants and see if there's something that can help with that. Or if they're nauseated, for me as a dietitian, I'm like, well, I can give you some tips, but you really need your medical staff to get you a medication management plan. And part of that is because if you're nauseated, it doesn't matter what food you put in front of somebody, they don't feel like eating it. Reminding them their nausea medicine is there for a reason. And they cannot wait until the food's in front of them to take their nausea medicine. They need to take it 30 minutes before they're going to eat so that they're most likely to feel like eating. They wait too long, the food's there, they feel they take their medicine, they don't feel well. By then, everybody else is done, or it's like, well, I don't feel like eating anymore. And so they really need to, I would say, front load the nausea medicine in order to make sure that by the time they sit down to eat, it's like optimal timing with the medicine. And same thing with this appetite stimulant. If there's some kind of a time frame when it's going to be most effective, they need to maximize their calorie intake at that time. The other kind of side effect that I think a lot of people maybe don't mention is their bowel regularity, especially if they're on pain medicine. And the patients don't always know when they should tell their provider about something, and then they wait till it's too late. And if they're constipated and stopped up, they don't have an appetite. So if they're saying, well, I don't feel like eating, but the problem is that they're stopped up because they're on pain meds or they're not eating enough fiber, so they just don't have it. Dealing with the constipation will help improve their appetite. But it's like all those pieces kind of coming together. That said, there are great little tips for each one that can be a first trial. But if it's not working, find the root cause, start using the medication. I mean, I think anyone on pain medicine needs some kind of bowel management regimen. And I find that patients need very specific guidelines, like here, oh, we're going to give you some nausea medicine. I need you to take this one every morning at 7 a.m. and these ones 30 minutes before you eat this time, so that they're not just left to like, well, I forgot, or I didn't think I needed it.
Julie, I want to linger here a little bit because Dane, I know this is one of your questions, but you had mentioned constipation, and sometimes it's easy as a PA, as a clinician, when they say, oh, I don't have a good appetite, we kind of are so focused on just solving that you might not have thought that, oh, maybe the patient is actually constipated and that's the reason that their appetite is low. So let's stay there. I would love for you to give us those specific nutrition suggestions that, okay, hey, if your appetite is low and we ask about their bowel movements, we found that they're constipated, what foods should the clinician be suggesting to resolve that issue?
Yeah, well, if you ask them if they're constipated, they might say yes or no. Like, you have to ask them, are you having regular bowel movements? And they might say yes. And you say, okay, how often? What is regular for you? Is that typical from before treatment? Is it painful for you? Are the stools kind of easy to pass? Like those types of questions, because to us as clinicians, we're like, okay, well, this is what constipation is. Well, the patient has no idea what constipation is. And they might be like, well, I poop every 3 days. It's a little painful, but it's fine. And that could, if it's sitting in there, I tell people 3 times a day to once every 3 days is a range of normal, but depending on the person, once every 3 days might not be normal for them. And that can be a sign that, like, yeah, that body needs a little more movement for it to feel like it can take more food in. So just teasing those things out with the patient. And then if they are constipated, I talk a lot about fluids. I talk a lot about physical activity. I talk about getting enough fiber. Now, again, that makes it difficult because the high fiber foods sometimes are not the foods that they can really tolerate. So if like the fluids, the fiber, the physical activity, they're already doing what they can, we can talk about fiber supplements or powdered, whatever, Metamucil, that type of thing. But if their constipation is from pain meds, that's not always going to help the problem. Like their GI tract is basically slowed down because of the pain meds. And so I just feel like there's a couple of different things that need to happen. It might be stool softeners. It might be some kind of GI motility thing as opposed to fiber. And if they're not drinking enough water and you throw fiber in there, that's like cement. And so we need to make sure things are moving and there is bulk. And also when they're given pain meds or they're getting some of these treatments that are likely to promote constipation, like telling the person up front, this is what we need out of your bowel movements. And if you are not getting this, you need to tell us ASAP, because we want to stay ahead of this rather than get behind it. Because some people end up in the ED from pain because of constipation, which is the last place they want to be. So yeah, I mean, when it comes down to it, fiber, fluid, physical activity are the things I would say are the like lifestyle pieces, and medication management and utilizing those tools are also really, really important. Also, if we are going to recommend fiber, it depends, but they probably need bulk and water and then a fiber.
Okay, Julie, I'm going to pause you here because if my clinicians have zero nutrition background, I don't want them to just tell the patient, you need to eat more fiber, right? Because that still isn't as helpful as I want the clinicians to be. So I want to make it really easy for the clinicians listening. Give us those top 5 foods that they can suggest that the patients can try to include in their diet.
Yeah, so pretty much all fruits, all vegetables, and whole grains. And then some easy ones are like nuts. So like a trail mix type of situation, if they're able to chew and swallow and all of that, I think those are easy grabbing. Fruits are typically pretty easy. Bananas, apples, even, and those can be also thrown in a smoothie if somebody needs to drink their fiber. Cereals, if you can see how much fiber is in a box of cereal, or cereal bars that are higher in fiber. Those would be the ones. Whole grain bread even is pretty simple and can give you 2 to 3 grams of fiber. So if they're doing that with their regular meals, like a source of fiber, fruit, vegetable, whole grain, beans, nuts, or seeds, at least one thing with everything they're eating, it will help. It will give enough to get them there.
That's awesome, Julie. I actually want to go to the opposite end of the spectrum. We talked about constipation. Let's talk about diarrhea. So we get patients come in that are about to start a new regimen that's they're pretty much guaranteed to have diarrhea. So can they adjust their diet to minimize the chances of having diarrhea? And if so, what do you recommend?
Typically with diarrhea, I would tell people to be more on the like low fiber end, especially if like this chemo or radiation or whatever it is really just going to mess with their GI tract, so it can't function very well, and we're just going to need to get through it. Then fiber foods are probably not particularly helpful during that phase, and so we use the term low residue diet, which doesn't mean anything to the typical patient. So low fiber and helping them. I know healthcare providers, we usually tell you to eat lots of fiber, but in this situation, we want you to eat foods that don't have a lot of fiber, because we're trying to get you the calories without anything that's going to irritate your intestines, and they're kind of irritated, just reminding them. This is like if you had a stomach bug, and it's going to last a while, and we just need to be really gentle with your intestines, and that means we want easy to digest foods. Fiber is great in most situations, but in this situation, we don't want fiber because it's harder to digest. And then usually people can think of comfort foods, white bread, white rice, things that are low fiber. We still want them to eat fruits and vegetables if it's possible, but if they're cooked, or if you take some of the peel off the apple, it'll be easier to tolerate. If it's cooked into like applesauce, that's easier to tolerate, but they still get that variety of food and feel like they're nourishing themselves. So those are the things I tend to say. I'm fine with dairy products, assuming they tolerate them. If this is kind of causing more lactose intolerance, I would tend to go with a lactose-free milk, cow's milk, because I think it's easier to digest and all the nutrients that are in it. But if they want to do a different type of milk, that's fine. So that's tend to be where I go. I would probably tell them not to eat nuts so much unless they do like a thin layer of peanut butter. That's probably fine. And I would generally tell them to stay away from beans. Most people know beans to be a high fiber food that might not be so tolerated during that particular phase.
Okay, I have 2 follow-up questions. I have heard of banana flakes or nana flakes to be given, and I'm curious what your thoughts are on that. And if you agree with it, if you could explain that to the listeners.
Yes, so that's a product that a lot of oncology dietitians use. So I'm glad you brought that up. And it can be helpful for diarrhea. It does not tend to cause negative side effects. So I think it's a great thing. Yes, I would definitely try that before I tried any like soluble fiber supplement because it is helpful. I don't think it's super expensive either. It comes in packets. Yeah, so that's definitely a good recommendation to look at. And you can get samples and that way people can try it before they have to pay for it. There is also another product that has some evidence for support, although can be a little pricey, and it's called Enterade. It is not like it does not give a lot of calories, but it was designed to help with the GI tract. And so it's a bottle and it is supposed to help specifically support the cells of the GI tract. And so they need to take it like 2 or 3 times a day for a couple weeks. And then that's supposed to help basically heal the GI tract in a way that it can tolerate food better. And some people have great response to it. I have a friend who's a breast cancer survivor who was on a medication it was an oral med that caused a lot of diarrhea. And it did help her, but some people have tried it. It doesn't help. So I've had a hard time teasing out who the right population is. But if it's like a patient that's just, you've done everything, the problem is it's expensive, although probably not more expensive than buying some of the other products people are willing to try. But it can be like the price tag can make people go like, never mind. But it's been helpful for some.
Okay, and then before we move on from diarrhea, because I'm sure people have a lot of questions about that, do you recommend an electrolyte replacement drink for all patients who have diarrhea, or kind of like what is your reasoning for suggesting something like Pedialyte or Gatorade or any of the other products on the shelves?
My feeling is if they are having a lot of diarrhea or vomiting for that matter, and they're likely to be out of balance and they're not able to eat much, I think they're going to have a better chance of staying out of the hospital if they can keep up with their hydration. Even if they can't keep up with their calories, they've got to keep those things in balance. Nobody wants to have to go to the hospital and get fluids. Now, if they need to, of course, they're going to feel way better. But I think if they can keep those things on hand, there are also some recipes for like make your own oral rehydration formulas like at home if they don't want to buy the product or their caregiver wants to feel like they're making it for them, that can just help keep them in balance.
Go along with the GI side effects. So let's talk about nausea. You mentioned some things about nausea, and I wanted to go a little more deeper with nausea because I find that a lot of patients during treatment, they suffer with nausea, but they also suffer with reflux. So what do you recommend in terms of trying to reduce the acidity in patients' diets and to kind of help with the reflux, as well as what do you recommend to minimize nausea with these patients?
Yeah, I mean, that's so hard. I tend to go back to the like small frequent meals. So not letting your stomach get empty and not letting your stomach get over full. And yeah, making sure that we've got motility going on. So it's not just hanging out in the stomach. The patient will need to pay attention because we're push high fat foods. Right? We're like eat high fat foods because they're higher in calories, but high fat foods, they sit in your stomach longer. So if that isn't work for them, then they might need to eat low fat, low fiber foods. It just really depends on each patient, but I would assess like, are they eating frequently and having small meals? Are they taking their nausea medicine on schedule? And then if they're still having a lot of issues, then I would probably cut back on the fat and the fiber and try to just get them like able to eat something. Sometimes liquid calories, it's digested faster because it's already kind of pre-digested, and it's easier for that to go through the intestinal tract, so it won't sit in the stomach as long. So kind of tweaking things to see and have the patient keep a log. That is generally always a good idea, because depending on the patient's personality, they may not, if they're not keeping a log, they can't even remember what they ate that morning. And when I ask people, what do you eat on a typical day? Or what did you eat yesterday? They can't tell me. They have to, so people cannot keep up with all that, and they shouldn't have to. So keeping a log, if they are having nutrition related side effects, just having them keep a log so that you can look it over, or if they have like a savvy caregiver, the caregiver can kind of see if there's some trigger foods or things in common. So you can get a pretty good sense just if they just write down like what they're eating, what they're drinking, and what time. They don't need to measure it.
I wanted to linger here just a second because reflux, whether in or outside of treatment, is so common. And what I actually hear a lot of clinicians do is just give a blanket anti-reflux diet that is avoid tomatoes and tomato-based products, avoid spicy foods, avoid orange juice, avoid chocolate, avoid caffeine. Like they rattle off this list of like 6 to 7 different things. So I would love for you to share your opinion on doing that, especially with an oncology patient, and if that's suggested or not.
With our oncology patients, we're just trying to get through, and I just need them to get enough calories. So I think it's kind of common sense that orange juice, or I love grapefruit juice, but that stuff is strong. Like those types of things, like probably don't need that just sitting around, but they could probably have a tiny bit if they really loved it, and it'd be okay. I tend to think more of the like sleep elevated kind of thing. Don't lay down right after you eat. I mean, our patients are probably laying down more than they're typical. And so reminding them about how their body is positioned. And those are the things I tend to go more to on reflux, because, yeah, I'm not a fan of taking foods off the list unless we know they are offensive to that particular person, or we know, oh, this is a really common, food that causes problems. So, yeah.
I agree with you. I don't really like when we give like 8 different foods that everybody should avoid, because it's not everybody needs to avoid them. And then we're avoiding some nutritious foods for no reason. So, and making it harder for the patients too.
Yeah.
So thank you for that.
I think the biggest thing is the diet, because I feel like everybody asks that question in the beginning. It's like, oh, what kind of diet should I be on? The keto diet, this diet, that diet, and should I avoid all sugars for the rest of my life? And I get that question a lot. So yeah, I think I want to do that because that's a big question we get a lot.
Yes. So those are really important questions that many people come in with. First of all, I would tell them they do not need to follow any real restrictive diet. I am not a fan of keto. I'm not a fan of intermittent fasting. I'm not a fan of whatever is a super strict kind of eating, because we just really need them to be nourished, and we need them to understand that that's number one, and that the data says that's the number one thing. There is not data for keto. And some people will quote this study about intermittent fasting. And I mean, it was the tiniest little study. It really isn't significant. Now, if somebody comes in and they're like hell bent on following whatever diet their cousin told them saved their life, or they heard people that I won't mention on the internet, I will try to work with them, because we need to keep them on the team and then trusting us. But if they're like, oh, I heard this, I heard that, I just go right into focusing on nourishing yourself. You need to get enough nourishment, and we don't recommend diets that restrict entire food groups, which is essentially keto will eliminate fruits and grains and like all these great foods. So I say, I'm not a fan of diets that eliminate entire food groups. I know it sounds boring and lame, but healthy eating is healthy eating, and I can give you some general guidelines on what's the evidence-based recommendations for treatment and survivorship, and kind of move into that so you do give them a piece. A lot of people ask the sugar question. I tell them that that's the number one most common myth, and that it's not true that sugar feeds cancer. Sugar feeds all cells of your body, and it's really glucose. It's the building block of energy for all the cells, and our bodies don't pick and choose which cells get what fuel. So it's an oversimplification to say that if you consume sugar, it's just going to make cancer grow. It doesn't work that way. Our bodies don't work that way. And it was an interesting theory they had, I think, back in the 70s, but has not proven to be true. And we would never tell you to eliminate, you couldn't have birthday cake with your grandkid, or a life is not worth living if you can't have a brownie. Those are kind of the things like, oh, we all can use some common sense. I'm not telling you to eat sugar all the time, although if that's all you can tolerate, that might be at some point what I do tell you. But, most people are like, oh, okay, that's good to know. I don't have to eat a special diet that's different from somebody else.
I love how you went to the glucose part, and that way of explaining it is, I think, is perfect and makes sense. And I'm definitely going to use that in my practice. So thank you for that.
Yeah, you're welcome.
For those of you who have more questions about some of the myth-busting questions that Julie had mentioned, go ahead and check out our previous podcast that we had done. We went over several different cancer-related nutrition myths, but I think that would be really, really helpful for you guys. Dane, thank you so much for these fantastic questions. I love hearing from people in the field who work directly with patients and can get these questions answered so you can better answer and educate your patients. So Dane, thank you so much for being here.
Thank you so much for having me. It's an honor, and thank you for letting me ask my questions today.
And Julie, as always, you are just a pleasure to have on the podcast. Thank you so much for your time tonight.
So fun. Thanks for having me.
All right, my friend, that's it for part 1 of my conversation with Dane and Julie. Now join us again for part 2, where we discuss the importance of nutrition for survivorship and specific nutrition interventions we should know about for preventing cancer recurrence. Well, that's it for today. So as always, let's continue to make our patients healthier, one exam room at a time. I'll see you next time.